All right. Hello, everyone. My name is Rajan Narayan. I'm an assistant professor of surgery at Loma Linda University. I'm very pleased today to be joined in a very special session of Meet the Mentor for SSAT by two luminaries in the field of clinical trials. So today we have Dr. Syed Ahmad, who is the Cancer Center co-director, Hayden Family Endowed Chair for Cancer Research, professor of surgery, and chief of the Division of Surgical Oncology at the University of Cincinnati. He's a nationally recognized leader in oncologic surgery and clinical trials. He has published over 300 papers, 40 book chapters, and has edited three textbooks, including the recently released ninth edition of Shackelford Surgery of the Alimentary Tract. He notably served as the PI on four NCI-designated cooperative studies, including SWOG 1505, which has shaped how we manage patients with pancreas cancers. We also are privileged to have Dr. Michael D'Angelica here with us, who is the Vice Chair of Education, Enid A. Haupt Chair in Surgery, and Emeritus Program Director for the HPV and Surgical Oncology Fellowships at Memorial Sloan Kettering Cancer Center. He's also the Professor of Surgery at Cornell. He is a nationally renowned leader in hepatopancreatobiliary surgery and clinical trials with over 500 publications, and he notably served as the PI on a number of investigator-initiated trials, including seminal work defining the role of hepatic artery infusion pump therapy in the management of patients with colorectal liver metastases. And in recent years, he led a pragmatic registry-based randomized control trial leveraging the ACS NISQUIT platform to study preoperative antibiotic regimens for patients undergoing Whipple pancreatoduodenectomy. Welcome to our two mentors today for our session. I also want to share that we are joined by Dr. Prav Chetani, who will be our co-moderator for the session. I'll let him introduce himself and we'll get started with a couple of questions for Dr. Ahmad.
Sure. Thanks so much, Raja. I'm Praveen Chaitani. I go by Prav, and I'm a second-year surgical oncology fellow at Fox Chase Cancer Center. I'm incredibly grateful to be here and grateful to Dr. Ahmad and Dr. D'Angelica for their time.
Thank you, Prav. Thank you, Raja.
Thanks to both of you for those very nice introductions.
Dr. Ahmad, we'll start with a couple of questions for you. First, I want to ask you, what are some of the key advantages of cooperative group trials like SWOG, and in terms of stakeholder engagement, protocol standardization, trial activation, and how do you manage the challenges of multi-center coordination in these trials?
Well, that's an important question, and thank you for that. So let me kind of walk you back in terms of how I got involved in cooperative groups, and that will kind of give you insight into the answer you're looking for. So when I first came out of my fellowship, I knew I was interested in clinical trials. I know I wanted to have translational questions built in, and I wanted to really tackle problems in a team approach. And I did that initially by just doing an institutionally based trial. And the one of the challenges that I encountered very early was accrual and sample size, where a single institution was unable to really meet the demands of a trial. And then the next step from that was trying to call colleagues and collaborators around the country to see if we could do a multi-institutional trial. And that came with its own set of challenges, but also was really limited by feasibility and sample size accrual. And it was based upon that I started to look at the cooperative group infrastructure as a means of really leveraging the power of hundreds, if not thousands, of institutions to work together to answer a seminal question. And so I got involved with SWOG early on and really learned about how the cooperative group mechanism works and the advantages that cooperative groups provide for investigators, such as core resources, centralization of processes, biostatistical support, tumor banks and translational infrastructure, imaging centralization, and of course, financial help with running the trials. And so that's how I kind of got involved with trials. So to answer your questions, I think it's the ability to leverage the power of hundreds, if not thousands, of institutions working together to answer a important question, and the infrastructure that involves that is really housed within each NCTN group.
Mhm. And so the other side of the coin there is the challenge of multi-center coordination. And what are the challenges that come with balancing a larger sample size and a larger number of institutions that you might not run into with a more regionalized approach?
So one of the challenges is making sure that we're all aligned in the question being asked, the approach to answer the question, the design of the trial. And again, the infrastructure that exists within a cooperative group really allows all these different investigators to come together. So the way a cooperative group study works is that a trial goes through a standardized process. We can talk about perhaps later in the session of how a study becomes a study through a cooperative group network. And then the study is then open to all members to open. So if you're a SWOG institution, then you're allowed to open that study, and each institution then analyzes the study to see if that's in a question that the investigators at their institution is interested in. Then a site investigator is then assigned to be a champion for the study at that institution. And so the way we kind of organize the workflow then is to have monthly meetings with all the site institutions. We send out updates through email communication, and then we have in-person meetings at the national biannual meetings, which is for SWOG held either in Chicago or San Francisco. And the site institutions can then come and have breakout sessions regarding these trials. And then, once a study opens, the work really begins, which is to keep accrual going. And so, we hold different types of seminars and series to keep the study first, foremost in mind in terms of accrual. And then we also offer authorship on the final paper and study, for the sites that have the most accrual. So it's really engaging the site investigators in making sure that there aren't any issues that need to be resolved, language within the actual trial that needs to be changed, inclusion, exclusion criteria, and then workflow issues in terms of sampling, shipping samples to centralized stations where translational questions are then evaluated.
Mhm.
Rob, if I can add something to that.
Please do. Yeah.
This is a mentorship series. And so I think Dr. Ahmad's story is a really important story for people to hear. I think he and I both worked within institutions trying to do trials. And they don't have the impact or the feasibility that you can gain through a cooperative group mechanism. And so Dr. Ahmad's story is very informative. And now when I hear fellows tell me they're interested in clinical trials, I talk a lot about getting involved with cooperative groups. I think it's a great mechanism for young surgeons to be involved. And as Dr. Ahmad will say as well, there are not enough surgeons involved in those cooperative groups. And so hopefully this will we can help mentor people to get involved like that. I think Dr. Ahmad is
Mhm.
more involved than I am in those things, but that's what I've learned as well.
Right.
Couldn't agree more.
So actually, one of the questions we had to save for later, it really piggybacks nicely off what you just said, Dr. D'Angelica. So I'm going to pepper it in now. You mentioned that most clinical trials are led by medical oncologists, or at least these cooperative groups. How can surgeons at different levels make a case for larger roles in these oncology trials? What can they bring to the table that is in terms of a different perspective? And especially those that focus on adjuvant therapies where the enrollment is heavily reliant on the surgeon's effort.
Is that question for me or for Dr. D'Angelica?
Why don't we start with you, Dr. Ahmad?
So I think that there's a misconception among surgeons that surgeons are not welcomed in the cooperative group, and that's so incorrect. I think if you go to a cooperative group meeting, the surgical input is very much valued, and the medical oncologists and radiation oncologists want surgical involvement in trial design, feasibility, and of course conduct. And then, depending upon the type of trial, many are in fact more relevant if it's run by a surgeon. It makes more sense that surgeons run neoadjuvant studies or surgical questions that are asked within cooperative groups. For example, Dr. D'Angelica, Dr. Litsky's hepatic artery infusion pump is a surgical question being led by surgeons. Neoadjuvant trials that I've run through both Alliance and SWOG, it's really based on surgeons. And I would say that over the last 5 to 10 years, there's been a lot more surgeons that now are involved in cooperative groups. So if you go to a cooperative meeting, there's the amount of surgeons that come to the meeting, they're involved, that have leadership positions within committees, within the whole infrastructure has increased remarkably. And so there are a lot of surgical mentors within cooperative groups. As an example, I run the surgical committee in SWOG. Um, 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 there are surgical mentors or surgical leaders within each of the other cooperative groups like ECOG and Alliance. And we have joint monthly meetings while the surgical group committees come together and discuss problems, trial design, and advertise each other's studies that we can help each other and open studies together. So I think there's a lot of opportunities for surgeons. And the surgical involvement really depends upon the type of trial. There's certain studies that aren't going to be led by surgeons. If something is metastatic unresectable and you're looking at novel experimental therapeutic studies, that's going to be led by a medical oncologist. But there are certain studies that are going to be championed by surgeons. Certain studies will be championed by radiation oncologists, and some will have co-PIs. And that's the standard now that most trials have co-PIs, a medical oncologist and a surgeon.
I think you'll agree, Sai. We've started to show that surgeons can run these trials successfully, and I
Yes,
would say that
absolutely.
many years ago that was not always thought to be the case. We've educated ourselves to be thoughtful about trials and knowledgeable about trials, and surgeons from years ago maybe perhaps were not so in tune to the science behind clinical trials. And I think hopefully we're doing a better job at training surgeons to be in positions to truly run them, and we're proving that
Absolutely.
we can do that.
And you just have to look overseas, and some of the most impactful studies that are being done in Europe are being run by surgeons. And if you even look within our own country and look at some of the most impactful studies that have been done over the last decade, many of them have been run by surgeons. And historically, if you look at surgical trials in general through the NSABP mechanism and Bernie Fisher,
Yeah.
that was a surgeon running trials. And so there's a lot of history behind and examples of surgeons who have been champions and have really changed the standard of care through work that they've done.
Thank you.
Shifting gears a little bit, the question that I kind of wanted to pivot to based on your comment earlier, Dr. D'Angelica, about the mentorship aspect of our conversation. I'm curious about when both of you, starting with Dr. D'Angelica, came up learning how to run clinical trials or to be involved. What level were you at in your training or as an attending? And how was that relationship at that time? And maybe talk a little bit about how residents or fellows or early career faculty may be involved through registry-based trials with Dr. D'Angelica or cooperative trials with Dr. Ahmad.
Yeah, I mean, my own story, I was always interested in trials. I remember being a fellow and writing, keeping a list of trials I wanted to do, being a relatively naive young trainee, but I was interested in asking those kinds of questions. In terms of mentorship, I think finding a mentor is critical. For me, early on in my career, I had many teachers and mentors, but probably from a clinical trials point of view, working with Nancy Kemeny here at Memorial Sloan Kettering was critical for me. She got me involved. She took me under her wing and really taught me about how to get trials done and ask answerable questions. And so I think the lesson that I learned is that you need to find a mentor, someone who's going to um, uh, promote you, help you, teach you, and not just help you do, ask you to do the work for them for a trial, but really promote you. And I was very fortunate to have someone like that really teach me and promote me and get me involved in trials and actually promote me as a PI of local trials before the registry trials, where she encouraged, she let me be the PI of trials that and so that was really huge for me. So I think you want to find people like that. Obviously, that's easy to say and difficult to do, but continue your quest for that. In terms of the registry-based trials, that I'm sure we'll get into more details. Our hope is that we can build it into a much bigger machine that will result in something similar, although it's a different approach to the cooperative groups. Although we are sort of just starting off getting that done. My hope is that we can build it into a bigger clinical trials group that we can then mentor people to do that. We're just in the beginning aspects of that. My hope is that within the next 5 to 10 years before I retire, that we get that actually running and other people to do it under our mentorship or the mentorship of many others.
Yeah, I would say that likewise, I was interested in clinical trials early on in fellowship. I actually wrote a concept for the very first trial as a third-year fellow at MD Anderson. And that's the study that I tried to open when I became a first-year attending. And you can take clinical trial design courses and similar training exercises, but there's no substitute to experience. And the only way you can get experience is to be present and get involved. So a lot of people say they want to do trials, but they don't take the next step, which is to get involved. So the way you get involved in cooperative trials is to go to the meetings, meet people, and sit and listen, learn how things work, learn the politics, the language, the workflow, and that takes time. You can't go to one meeting and expect to become a PI of a trial. There's a process that's involved, and the process takes sometimes a couple years, to first go learning the landscape, the people, and identifying people who will be mentors. What Dr. D'Angelica said is really important. But the other thing I want to highlight is that his mentor was a medical oncologist. The first person who what I would consider a mentor for the very first cooperative group trial that I ran was also a medical oncologist. So your mentors can come in different types and specialties. They don't have to be surgeons. Most people have multiple mentors. You can have a medical oncology mentor, a surgical mentor, and sometimes you work as teams. One of the things that all of us like about cancer, it's a team sport. And so even though, we're talking about surgeon, clinical trialists, it's a team sport. And so your mentors can be people who are not surgeons. And the only way to be exposed to them and learn from them is to go to these meetings, introduce yourself. Like the very first time I got involved in cooperative group platform was I was sitting in the room. This is like the third cooperative group meeting I was at. And all I did for those first three meetings was just sat in the back of the room and listened to all the trials being proposed and how they were vetted and how they were critiqued and constructive feedback was given. And then someone said, hey, we need a surgical PI, co-PI for this study. Who wants to volunteer? And I just put my hand up. And that was the first domino. And that wouldn't have happened if I wasn't there. And then I started working with Larry and we wrote a trial, went through the process, got it approved through CTEP. And that's another story. That trial unfortunately never accrued based on trial design. So there was some lessons learned there. But you can't the only way to learn is to actually do it, and the only way to do it is to be present and get involved. And your mentors come in lots of different types, and they can be medical oncologists, it can be surgeons, sometimes it can be multiple people.
Dr. Ahmad said something very important. We've all failed at trials. I can list all the trials I tried and failed, but that's an inevitable part of what we do. And don't think that you're just going to show up, do a trial, have a positive outcome, and change the world. It's just, of course, not reality to think that way. And failure is part of learning. And hopefully, as we all get better as mentors, there's less of that. But it's probably inevitable that you're going to think you have a great idea and it just doesn't accrue, or it's not feasible, or it doesn't work out for some other reason. But you learn from all of that and you persevere. And I think we would all agree that perseverance is probably much more important than being a genius. God knows I'm no genius. So that's an important point to make.
The one thing I'll say about having a career in clinical trials, it requires a lot of patience and perseverance. It's not like you have a wet lab and you're going to do a PCR or a Northern and you have the results right there. And this takes time and patience and effort and sometimes years. I've been involved in cooperative group studies where we had a study from concept to approval through CTEP within 6 months, and I've been involved in cooperative groups trials where the concept to approval took 4 years.
Yeah.
And so, if you believe the question is worth answering, it's worth the work.
Great points, and especially I think from your comment about the need for patience and the comment about learning from sort of missed opportunities, that might be akin to the surgical training or the surgical mindset as well, where you take every case as a growth opportunity. So maybe for that reason, surgeons are very perfectly fit to help with leading surgical or trials in general. Question I have for Dr. D'Angelica, we were sort of beating around the bush about registry-based trials, but maybe just to share with our audience, Dr. D'Angelica, if you can give us a brief overview of what are registry-based trials and how they may contrast from trials developed in the cooperative setting, potentially highlighting maybe the time frame of the one that you led recently from conception to approval and launching for accrual of patients, and touching on maybe the role of trainees or early career faculty that may have been involved in the execution of that trial.
So I think from conception to publication was about 8 years, something like that, 7 or 8 years. I'm in a registry-based trial. It comes in different flavors, but for the most part, it's a randomized trial organized around data collection in an already established registry. The idea being that someone or a hospital or some entity has already invested, literally financially invested in data collection. And if that data collection fulfills what you want to answer or has the data that will answer the question, you can build or design a trial around that. I would say by definition, they are relatively pragmatic, meaning you're not controlling for every little confounder. And you're not going to really get caught up in every little detail. It's sort of real world pragmatic. And there are pros and cons about that we can discuss. There's generally not funding for correlative studies, which are wonderful to do. And I would encourage whenever possible to do that, to ask and answer as much as you can. But, money doesn't grow on trees. And when you can't, and so I think it's an ideal way in our country to ask surgical questions, purely surgical questions, management of perioperative interventions, or theoretically in the future, even technical questions, because there's not a great funding mechanism for those kind of questions. If I went to a cooperative group with that antibiotic question, I don't think there would have been a lot of interest. It's not really what they're there to study. I totally understand that. So this was developed out of a need, right? And that's where these kinds of ideas come from. We had a need, and we had to get creative to make that happen. It was basically from a committee that I was asked to start at the AHPBA on clinical trials, and we had no idea how we were going to really do anything. And this really became the idea. And the NISQIP mechanism was perfect to ask perioperative questions that could impact 30-day morbidity or mortality questions. And that's what we'll continue to build on. But I think the trade-off is you don't have a perfectly designed trial. You're generally speaking not going to have money for placebos or blinding or things that are generally accepted to be the ideal way to do trials, although that level of control is somewhat debatable. I give a talk all the time about a trial that we did here, which was randomized, double-blinded, placebo-controlled, the absolute perfectly designed trial. And it didn't impact anybody because it was perfectly controlled, but it was done in a single hospital. Whereas more of a real world trial, I think, is more acceptable or more easily accepted by people in the field, especially if it's a relatively simple question. And as I think anybody who does trials will tell you, the simpler the question, the easier the answer, and the more acceptable the answer. The more complex, the easier it is to criticize. So that's how the registry-based trials happen. And there, by the way, they did exist in Europe. I think in cardiology and other fields in Europe, they've done registry-based trials where they have more registries.
So I'd like to add to what Mike just said, and I think it's an important concept for people to understand. If you do a study through the cooperative group or whether you do a registry trial, the money that you require to conduct the trial is for the trial itself. The translational questions, whether it's in a registry trial or in cooperative group, has to be funded through some other mechanisms. So even within the cooperative group, if you have translational questions built into the study, that has to be funded from other revenue streams. So sometimes the cooperative groups have pilot funding that you apply for, just like you would at an institution. But it's also a great opportunity for young investigators to leverage the translational component of a trial for extramural funding, because a lot of people, are trying to get funded, for various reasons. And if you have a cooperative group study and have a translational question, you have basic science collaborators, that's a perfect way to then write an extramural funding for a R01 or R21 or some other mechanism that can then be the strength of the trial, and the cooperative group can be leveraged for extramural funding.
Yeah, and indeed, that's what we're trying to do, actually. And I think that was the next logical step for we're the follow-up antibiotic trial, which is relatively simple clinical trial, but Ryan Ellis and I are trying to write grants. Unfortunately, things have been put on hold due to funding issues, but hopefully we will find mechanisms to sort of
Yep.
build in the correlative studies to the clinical trial. I think that's the ideal way to do it.
And most cooperative groups have a foundation that is related to the cooperative group, but have an external board that raises money for the cooperative group. So for SWOG, that foundation is the Hope Foundation. And so they raise money specifically for these types of mechanisms where people can then apply for grants that is then utilized for translational research.
That's also kind of a great point about, especially from the context of being an early career surgeon scientist, if you're interested in basic science, cooperative groups and even registry trials may have an opportunity for correlative studies in the future where specimens could be acquired or data can be gathered for a basic science endeavor, in addition to more outcomes or clinical trials level question that you might be pursuing. You know, both of you probably know, or all three of you know, that yesterday the Preopank 2 trial was published out of the Netherlands. And so just another amazing study and an opportunity to kind of wipe our face in the mud about how Europe has really mastered running clinical trials relative to how we've been able to do that as a united front, at least as a country. I'm curious from your perspectives, just going in the future with how limited funding is from a federal source now and how the registry-based trial is a new entity and cooperative groups have existed in the past, and we have sort of a presence there from the standpoint of the surgery committee as Dr. Ahmad leads, and opportunities for early career folks to pitch trials in that entity and potentially to the registry format in the future. Where do you think cooperative trial settings and registry trial settings will grow, those mechanisms in the future, given limited funding or the need to compete with European infrastructure for running clinical trials?
Well, first of all, I wouldn't say it's all of Europe. The Dutch are really responsible for a lot of this, although it's true in Europe. You have to realize it's a very different system. Most of the healthcare systems within Europe first of all, they're smaller countries. We're a much larger country. And second of all, they're done with nationalized healthcare systems, where they're all much more united in how they approach research and clinical care. We're a little bit more disparate in how that happens in the United States, so it's a bigger challenge. And for reasons that I don't completely understand, there's a little bit more funding for clinical trials, although they do less of the basic science than we try to do in the United States. So, I mean, I think the Dutch, in a very small country where it's just part of their culture that they do these trials, and they accept equipoise much easier than Americans for some reason. They really get these done very quickly, and the patients are more accepting of it. And I think it is now slowly working its way more into our culture. I think that's fair to say, but I think we can do an even better job, and hopefully that continues to happen within our healthcare system. I don't know what your take on that, Sai, is. I think it's complicated.
Yeah, I think it's complicated. I do think you point out the important reasons why. One is the centralization of the care and lack of competition in terms of the clinical trial infrastructure. So if you look at the US, we have a set number of cooperative groups. We mentioned some of them: SWOG, ECOG, Alliance, NRG. The NCI Canada also has a cooperative group as well. And they all have disease groups within them. So each of those have a pancreas disease group, a hepatobiliary disease group, and they all are trying to open the same trial. So who's going to, and then there's a centralized NCI mechanism that oversees that, the steering committee, the GI steering committee. And they have to decide which concept is the best. And so sometimes that study's open just only in that cooperative group. However, the sample size requires a larger accrual than the sponsoring cooperative group then petitions the other cooperative groups to also open the study, and that's called an intergroup study. And so if a study sponsored by SWOG is then opened by the NRG, ECOG, Alliance, and then becomes an intergroup study, so our SWOG 1505 was an intergroup study. And so there's a lot of competition that comes here. And so people may have competing trials that they're doing or applying for. And so because of that, politics gets involved here as well. And so, I think in Europe, that's limited because there's only a single, especially in the Netherlands, there's a single mechanism, and so everyone's working with the same playbook, whereas everyone here, people have different playbooks. Um, I do think that there are opportunities to improve our system here. Um, Going back to your early question about limited resources, I think that's a really, really important question because with the NIH budget cuts, each of the cooperative groups have a smaller budget, and they're having to make some very difficult decisions about which studies are worth opening. And a lot of it is which ones will have the most return on investment, which ones will change practice, and which are the most feasible studies. So studies that perhaps would have been open 5 years ago, 2 years ago, will no longer be open. So there's going to be much more stiffer competition in terms of opening studies and being more novel with trial design, feasibility. The other thing that's happening with cooperative groups is that cooperative groups are partnering with pharma agencies to help run trials. That was unheard of in the past, but now each of the cooperative groups have established relationships and are opening specific trials that are being done in partnership with the interests of the pharmaceutical company and utilizing the infrastructure of the cooperative group to get their studies done. And that allows a financial stream for the cooperative group that's outside the NCI. And so we have to start thinking, outside the box. We have to be much more strategic in what studies are being opened in terms of return on investment, the questions that need to be answered, and maybe some of these other questions will be answered in the future when the budget increases. But as a young investigator coming up with trial designs, it's really important to get input from senior people about the feasibility and the practicality of the question and idea you have before you devote too much time towards that end.
Thank you. I want to take a step back and sort of imagine that you're a new young investigator, you're breaking into the scene, you've watched now this webinar and you've said, okay, I understand the vernacular. What is the next step? What's the first step that you would make as a young investigator to start your education in clinical trials? If you had to pick one avenue to kind of invest your time in, what would that be? I have a Dutch passport. Should I go to Amsterdam and try to work with Dr. Korkamp out there, right?
I think Dr. Ahmad talked about getting involved in the cooperative groups, and I think you'd be welcome with open arms, and I think that's great. And raise your hand when they're looking for volunteers, and I think the idea of being a team sport is really important. Show up, be a good teammate. That's really important. I would actually encourage one other thing, and actually, Dr. Ahmad also mentioned the clinical trials courses, which I think are worth it, but they're short, and you probably don't, usually develop your own protocol at the Vail course or other courses. But that's kind of short-lived, and I did it. It seemed like a million years ago, and it was over very quick. But the other thing I would encourage people to do is get involved either through the cooperative groups or locally in your hospital, either in your IRB committee or every hospital has like a scientific review committee. We call it the research council here, but every hospital has a different name for it.
We call
And
it
I will tell you, I spent, it must have been 7 or 8 years, and I was fortunate to be promoted to run that committee here. And I learned a tremendous amount about clinical trials, watching them get criticized. And I was so fortunate to be in the room with some really experienced investigators. And you start to learn and recognize patterns of criticism and understanding the pitfalls of trying to answer questions with these trials. And I will tell you, get involved early from a learning perspective. And also, you may find a mentor. You may find some people, you'll make friends with other people, probably most of the medical oncologists or other medical doctors. But you'll have people you can reach out to for help. But it was an incredibly valuable thing for me to do early in my career. So that's something to think about.
I think those are really important points. And so I think, yes, clinical trial course is important, but they just are a tip of the iceberg. You're not going to get a lot out of them other than learning the overall framework of trial design, different types of trial designs, things like that, statistics. I think getting involved with what we call the PRMC was also something I did very early on. It allows you to see lots of different trials, read them, read the introduction, the biostatistics, the feasibility, budget justification, things like that. And the other thing I would say is that at your institutional level, get involved with the cancer center. So I'm a cancer center director, and I would say most surgeons don't know how a cancer center works. You should know how a cancer center works, in terms of the research programs, the CTO, and the crosstalk that occurs between research programs and CTO. So most cancer centers will have 3 to 5 different research programs. You should know which research program you're a member of, be involved in those working groups. That's where you can also come up with feasibility trial design ideas in working with other collaborators that are not necessarily surgeons in proposing studies. And then the next step is, identifying an institutional mentor who can help you. You have to be honest about what your goals are and what you want to do, and coming up with ideas that you can work. And then when you come up with a good idea, that's when you take the idea to the cooperative group. So parallel to the institutional involvement is also get involved with cooperative groups. And every cooperative group has a surgical committee. So the first thing you should do is what in your institution, find out what cooperative group your institution is a member of. Sometimes institutions are a member of 1 or 2 different cooperative groups. Sometimes they're a member of 3 different cooperative, but there's usually a major cooperative group that your institution's involved with. Find out which that is, and then find out who the PI of the committee chair is of the surgical committee in that institutional group, and just email them or call them and say, hey, I want to come to the national meeting. Do you have time to meet and chat and get involved? And most of these cooperative groups, surgical committees have monthly meetings, so you get involved with that. And it's that initial step that you need to take to get to know people. And then what happens, it's interesting, is that you then start meeting at other meetings. Like, I always have people email me, hey, I'm coming to SSO. Can we sit and talk? I have a concept I want to go over. Or I'm coming to the DDW meeting, or the I'm coming to the ACS, and then you'll start having these meetings at other national meetings, and it kind of just goes from there. But trials, institutional involvement, institutional mentor, come up with an idea, take it to the cooperative group, get involved with your cooperative group, and next thing you'll be a seasoned veteran.
It's incredibly helpful. I just want to pepper in one last question if we have a moment. You've shared decades of experience with all of us, and we're so grateful for that. If we could have you end with one thing, looking back with the retrospectoscope, one thing about the finances of clinical trials and one thing about the structure of clinical trials that you wish you knew when you were sitting, let's say, in our chairs on the other side of the screen here.
Well, I would say I worry about the future of academic medicine. Maybe it's just a time where things are taking a dip, but finances are going to be a problem. I have seen finances be less of a problem and rise to a very big problem at the local level and the national and international level, and that worries me a little bit. But you do need money, and I think what was stated earlier about engaging with private money, be it pharma or philanthropy, may become more of the solution in the future. And I think doctors do not naturally feel comfortable asking for money in whatever way that is, whether that's a grant application or a meeting with somebody who's going to donate to your research. Or I don't think the personality that goes into medicine naturally does that very well. And I am certainly guilty of that. But I think we need to be practical about how we bring in finances. I mean, I think we're doing some of the most noble things with that money, and we should not feel guilty about it. And we have to try to get what we can so that we can improve the outcomes for our patients. Because ultimately, well-structured research is really the only way to improve things for our patients. And if we couch it in those terms, it's the best spent money you can imagine in medicine, aside from the actual direct clinical care of patients. I don't know if I have an answer to what I've learned most about what I think I knew about asking questions. I think you have to ask a good question. We could spend hours talking about what a good question is. Probably what you have to think about more is feasibility in the context of a good question, and that's financial, accrual questions, acceptability in the general population of people who do this kind of research and will read this kind of research. There's a lot to that. But I think if you have the right mentors, they'll help guide you early on in your career. And I think that's ultimately what this is all about. Find people who've been involved that there exist out there. And as we spoke about earlier, they may not necessarily be in your field. They can be radiation oncologists, medical oncologists, or even other specialties who've done trials.
I would say that first of all, in terms of why this is important, one of the things I always teach my residents is that as surgeons, over the course of a career, we see thousands of patients and we help them and their families. And when you walk away, when you retire, you've helped thousands of patients. That's really noble. But when you're a clinical trialist and you come up with a trial that changes the standard of care, you've helped thousands of patients at once. So you work at a population level and you also work at the ground level taking care of patients. If you're a bench researcher and you come up with a new target that leads to drug development, you've helped thousands of patients at once. So you should strive to move the needle. And one of the best ways for surgeons to move the needle outside of having a wet lab and coming up with a new drug is conducting clinical trials. So I think it's really, really noble and important in terms of contributing to the field. So it's worth the effort. The thing I would say is what I've learned is that it's easy to come up with a concept, and it's even easy to get the study going. Now, I'm obviously being a little bit facetious. It's a lot of work to come up with a concept and a lot of work to get it open. But the real work is once the study is open. That's where you have to be tenacious. There are more studies that open and close without accruing, without completing accrual or answering the question, and all that time and resources wasted. The real work begins when the trial is actually open and you've got to get it across the finish line. And that means being just tenacious. Like a good example is like the study that Mike is leading with Dr. Litsky at Duke on the hepatic artery infusion pump. I mean, they're having monthly conference calls and they're, calling institutions, are you accruing patients? Why aren't you accruing? What are the barriers? Calling people around the country and just really pushing it and pushing it. So I think the real work of trials really is afterwards. And I just thought that it was going to be an automated process. You open the study, it's going to go to cooperative groups, they're going to enroll, boom, bada bing, bada boom, you're done, publish results. And it just doesn't work that way. It takes a lot of work, up front and even after the study's open. And you have to be a pit bull. You have to be tenacious. No one hands it to you. You've got to earn it. But the reason you do it is because it's worth doing it because it moves the needle. You work at a population level, and if you can change the standard of care, that's your contribution to science.
Such a great point. You have to own that question. And, we're terrified that our trial will not finish and we'll be seen as failures and we can never study this treatment again and surgeons can't do trials. And so there is a lot on the line and you have to own that and really push for it. I couldn't agree more. It's not about being a genius, fortunately.
You got to be tenacious, and there's politics involved in doing trials. And so the other thing is you have to know how to navigate the politics. Like sometimes when you're presenting, the way it works is you get through the committee level, then you go to the executive committee level, then you go to the national level, and you present at the GI steering committee, and if one person says a negative comment about the trial, it's like a domino effect, and the next thing you know, it's like, what just happened? And so, there's politics involved, and you kind of have to set the stage and have people ask the questions and send the trial to certain people so that they ask the right questions and get the momentum going during that review process. And so, there's always someone from another cooperative group who also has a study that they want open, and so they're going to say something bad about this study because it's a competing study. There's all these politics you have to navigate as well, and it's a dog eat dog world. But again, if the question is something you're passionate about, it's worth the work and time and effort.
Well, on that note, I think we really appreciate your time today. We'll close for today, but thank you so much. And we really appreciate your insight and your mentorship on this subject. Thank you, Dr. Chitani, as well for the co-moderation for this session too. And thank you all for watching.
Thanks for having us.
Thanks for having us.